Thank you. And we're going to go ahead and do the reading of the mission. Lori?
Okay. Macomb County Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence.
Thank you. And we're going to move on to adoption of the agenda. Do we have a motion?
So moved. Support.
Thank you. Any discussion? All in favor?
Aye.
Any opposed? Motion carries. Moving on to item 4, hearing of the public. Anybody from the public that would like to address? Anyone from the public? Okay. There'll be another one at the end if anybody wishes to speak at that time. Moving on to item 5, the minutes. Approval of the minutes of the regular meeting of the CMH full board held Wednesday, January 24th, 2024. Do we have a motion? And
Support.
any discussion on the minutes? Nick?
I would like to abstain as I was not president.
Okay. Note that Nick is abstaining. Any other discussion? All in favor?
Aye.
Any opposed? Motion carries. Item number 6, approval of standing committee meeting minutes and recommendations. Approval of the CMH Board Program and Budget Committee held on Wednesday, February 14th, 2024. Do we have a motion?
So moved.
Nick, and then support by Donna. Any discussion on this one? All in favor?
Aye.
Any opposed? Motion carries. Item 7, we're going to take a motion to approve A through E, which has been previously approved. Motion? Any discussion on them? Tracy or Tony, you want to speak to any of the items? Okay. Any other discussion? All in favor?
Aye.
Any opposed? Motion carries. 7F, this is a new item, and it's a request to approve QUEPIC, which is Presentation Evaluation FY23 Quarter 1, FY24, the Narrative FY24 through FY25 Work Plan FY2024. Tama?
Good evening, everyone. Today, I'll be presenting on the Quality Assessment and Performance Improvement Program. There are 3 documents included in your package today. The first one is the program narrative. This document outlines requirements for the QUAPIP as prescribed by the Michigan Department of Health and Human Services. The second document is the program evaluation. This document provides evaluation of the Quality Committee oversight on ongoing implementation of quality indicators, processes, outcomes for 2023. The third document is the 2024 Program Work Plan. This document identifies goals and objectives which align with the QUAPIP narrative, input from the Board of Directors, Executive Leadership, Quality Improvement Committee, persons served, and providers. Next, I'm going to give a brief highlight on a few areas of evaluation from 2023. First is the PIP, which is the program improvement plan. The state of Michigan requires MCCMH to have at least 2 performance improvement plans. One has to be clinical and the other non-clinical. So for the clinical performance improvement program that we had is to improve follow-up after hospitalization and also to reduce racial disparity. The second performance improvement project was to increase HAP enrollment members to meet the state's requirements. The next section that I would like to highlight is the events data review. Every single incident report that was received in 2023 was reviewed and classified as either a sentinel event, critical incident, risk event, or an immediately reportable event to the state. The Critical Risk Management Committee reviewed every sentinel event and approved them, and in some cases, a root cause analysis was required. The next section I would like to highlight is the audits. In 2023, we reinstated the residential audits. And by the end of the year, we had completed 36 residential homes, and also corrective action plans were implemented and approved. An in-person hospital audit was completed. If a hospital scored below the 95% of compliance, a corrective action plan was also implemented. For the Medicaid encounter verification, clinical records were reviewed and also payment documentations were randomly selected across 80 vendors for mental health services and 21 vendors for substance use services. For services that were provided and did not match the services how they were paid, recoupment was required from the provider. And for providers who fell below the compliance rate of 95%, we also required for them to provide a corrective action plan. For committees, the Utilization Management Committee, Behavioral Health Treatment Plan Review Committee, and the Credentialing Committees were restructured, and now they are fully functional for 2024. Some of the areas I would like to highlight briefly for the work plan for 2024 is the primary provider audits. So for this year, we are working towards reinstating the provider audits, which will include chart reviews, credentialing, and training. We are also planning to implement a quality tracking system to track all potential quality issues so that we can be able to have accountability and consistency in issue resolutions. Member satisfaction survey is another one that we plan to continue with. We did one last year and we're going to do another one this year. In addition to that, this survey is going to be ongoing on the website, just in case someone wanted to complete one during the year. Provider satisfaction survey is another area that we did not do last year, and we plan to work on that for 2024. Performance improvement projects are projects that has to go all year round, so we plan to continue on those initiatives. In addition to that, we are also planning to continue work with the Maheli Group to assess any gaps and implement mitigations when necessary in preparation for our CAF accreditation or our NCQA accreditation. Any questions?
No questions? Okay.
So all of this, you converted to, right? This just answers anything, and I did read through. Okay, just making sure.
So just to highlight, I just wanted to give a few highlights because I was warned by Tracy, I cannot stay here for more than 10 minutes. So I have everything else in the package, but I have to give
I need to make sure on record that is not true.
I said be concise and efficient. I gave no time limit.
Yeah. So
I guess I do have a question. on the indicators, and I kind of already emailed Tracy this afternoon with some of my questions, but on the indicators that we didn't meet and the standards were like way below, I noticed that some of the stuff that you're working on is increasing availability for appointments. Are there any other ways that because those concern me. You know, I was a therapist in the county for many years, and those were like really highly emphasized to be met. So it concerned me that they're not being met. Is there any other way, you know, a carrot that you could like push to be able to meet those? Because that is concerning to me, that people aren't getting their assessments within 14 days and that they're not getting treatment quickly because they need it. Right. Is there some other way? And it looks like this isn't the first year that we haven't met that standard. And that's a really important standard, I believe, to be met. So I'm wondering how else we could possibly push to meet that standard, because when people need to get treatment, they need to get it pretty immediately.
Right. Thank you so much for that question. I'm glad you asked. So some of the initiatives that we are taking, we are actually reviewing our availability internally with our internal providers and also externally. So one of the things that we are doing is to make sure that our providers are letting us know what their availabilities are. And another project that we are doing is a ROC program, where we are looking into some of the areas how we can improve this number. And we are finding out, and we are trying to realign the responsibilities of our hospital liaisons. So we are doing it in a way that we get to engage with these individuals when they are admitted in the hospital. So we start to plan for discharge accordingly. So as a provider, if I know I have someone in the hospital today and they are going to be discharged next week, I can start looking at my schedule and making sure that I can get them into an appointment within 7 days. We are also running a lot of data, and we are reaching out to providers individually and showing it to them and say, here is your data, here are the areas that you were deficient, here are the number of individuals that you were not able to see within 7 days after discharge. What are you planning to do? How are you going to fix it? So then when they have this data, they can look at it and say, oh, I could have made a small change. Instead of 8 days, I could do 7 so I can meet the KPI. So we are doing all of those things. And we are also looking at transportation, which is one of the big challenges that we are having. Some individuals have an appointment, they don't have transportation, so they don't show up, or they would have to reschedule. And when they reschedule, they come after 7 days. So sometimes we still see them, but it's outside of the 7 days. So one of the pilot programs that we have is with Harbour Oaks Hospital, because they are able to provide transportation on the day of discharge to the follow-up appointment. And we have seen some slight increase or improvement, but this is just one hospital. So we are still working on that. Thank you.
Through the chair, some other feedback is we're trying to establish best practices. So an example of best practices is having open hours where somebody can come into an intake immediately, not waste, as you know from your experience in the past, you have no-shows, right? So we're trying to work with the providers. We already do this, but we're trying to work with them for them to implement open office hours where anybody can walk in during these times and get an intake, because then that removes the wait for those people who really want to access it.
Any other discussion or questions? Because we do have a motion and support on the table. Well, thank you.
Thank you.
We appreciate your presentation. All in favor? Aye. Anybody opposed? Motion carries. Item 7G is a new item. Request to approve 5-year lease located at 105 Cass, Mount Clemens, Michigan, 48043 for Substance Use Engagement Center. This has been approved by legal. Do we have a motion?
Support.
Wayne? Helen?
Yeah, thank you. And I'm going to ask Nicole Gabriel to come up as well if she wants to go to the mic in case she wants to add in, because she's working diligently on this project with me. Nicole is our interim substance use director as well, for those of you who might not have met her before. She's been with our department for many years now, and I don't know how many years with
7.
CMH as well.
CMH, I don't know.
She goes back a while for that as well. So new to this interim role, but not new to any of the services or things that she's helping to assist with. So thank you for that, Nicole. We kind of gave you a little heads up at our last meeting that we had finally found a property for our engagement center. It's been a very long search, so we're very happy to find the property. We did include the picture for you, so it might be a building you recognize as you come to downtown Mount Clemens, because it is easy to find and locate and identify. So we're really happy about that as well. Right at the corner of Cass and Gratiot, because we think that will really help the community over time get a good understanding of where it is, how to find it, and things that's part of the real important piece there too. So we've worked with the landlord who's willing to make any the renovations that we need for the facility. And so we're ready to move forward. Legal had reviewed the contract, as you can see, and so we're very excited to get things up and running. The goal is to be in at the beginning of April. That's when the lease would start. And then we're working with our contracted provider, which is Care of Southeastern Michigan. And we told them we are seeking approval tonight. And with that, then they'll go ahead and they'll start posting for hiring for some of the positions that they need. And we'll go through an extensive training and get everybody on board and do lots of wonderful things. Part of the goal is also we want to roll it out to the community and very strategically and let law enforcement know, our hospital partners know, and probably do tours so that people become familiar with the program as well, because we really want this to be a solid resource for the community. And Nicole's can tell you a little bit about her plans for tomorrow.
Yeah, so tomorrow we're doing a walkthrough with Office Express to hopefully get furniture. So we have desks, we have a reception area, we have seating, we have places for people to rest and relax. And then we're working on getting appliances so people can come in, they can do laundry, they could maybe heat something up in a microwave or get something out of a refrigerator, just so that they can kind of get comfortable, get relaxed, and then get set up with the resources that they need.
Any questions? Antoinette?
How did you guys decide, and I apologize if this was brought up at the last meeting, I was not here. How was this location picked over the other ones that you looked at? Because I know that this is not an easy process and not a short process. So how did you decide on this location?
So the first one that we looked at, we found that there were issues with zoning, so that kind of took that one off the table. And then there were some other ones that we reached out to and didn't really get feedback from. We were also looking at what the construction needs would be. So a lot of the ones that we looked at, it would be a lot of work to renovate. We were hoping to get one that was also in Mount Clemens, I think. Mm-hmm. But when we asked for the proposal from that owner, we did not get a response. So then we moved forward with looking for a different property. So we wanted to find something on a bus line that didn't need a lot of construction so that we could get it going as soon as possible.
Okay, and then last question, do you foresee any issues with, and I know you said that you were gonna kind of make the community aware and all of that. Do you foresee any issues with that? Because the last time, and definitely not a county entity, but a private entity tried to do something with the help of substance abuse, and the city, the community pretty much came together and was like, no. But I think that had more to do with it was a private entity and not a county, but still in the same arena. Do you foresee any issues?
There could be potential questions from the community about it. I think that for the treatment facilities, it's a little bit different because people are there long-term, they're staying on site, where this is more of like come in, get linked with services, and then you're going back out into the community. So people aren't gonna be staying, more than a few hours. So we're hoping that it will fill a need. It will keep people from going to the hospital. keep people from going to jail, keep people from being on the street and not doing well. So, yeah, we're hoping when we reach out that everybody in the community will, you know, see that this is going to be a positive and benefit.
So I could add as well, we've done some presentations of the Safe and Healthy Macomb Plan. I'm sure you're familiar with that because it came to the Board of Commissioners. And so we did have meetings with first responders and hospital emergency room staff and leaders. And so it was an overwhelming response from that particular group. And we've brought that out as part of some of the other community partners that we've gone to with the Safe and Healthy Macomb Plan, which is the use of the opioid settlement dollars. And so we every time we're bringing it, we're also bringing this as part of a crisis continuum plan, which is part of that overall plan. And so far, all the feedback we've received from the different groups that we've gone to has been very positive. They see it as a very needed service in the community.
But I guess and it's not really a concern at all. Not the feedback from
Mm-hmm. Mm-hmm.
as a resident. All the county, like, buildings in Mount Clemens, right now in particular.
Antoinette, maybe I can add, Nicole actually has a meeting scheduled. Purposely reached out to the mayor and the city manager, and there's a meeting scheduled, and the plan is to not sign the lease without until we ensure. I realize they don't have complete control to your example, but I do think you have a legitimate concern. So we were trying to start with there. We also have connected with the, forgive me, I don't want to use improper terminology, but the lieutenant, I could be wrong on that, who oversees Macomb County Sheriff's specifically area for Mount Clemens, to try to connect with them and kind of brainstorm on who are those other key people that we probably need to start giving them a heads up, make sure that their concerns are heard, right, and reassure them of kind of how this is going to look, and if they do have concerns, how they can share those concerns. I do think you have a very valid point, and again, that's why Nicole is meeting with the city manager and the mayor to try to start those conversations.
Mm-hmm.
Okay, that's helpful.
Yeah.
Thank you. Nick?
Just real quick, some of the names look familiar. Have we worked with this landlord and/or this provider in the
I
past?
didn't, no, I don't, TJ's shaking his head, no, I didn't recognize the name, no.
It just sounded familiar. I'm just
Sure, maybe in
curious.
another round, but not for landlord relationship.
Any other questions or comments? Okay. Thank you, guys. We do have a motion and support on the table. All in favor? Aye. Any opposed? Motion carries. Item number 8 is a receive and file. There's no items. Item number 9, resolution. No resolutions. Item 10, vouchers. Requesting final approval for payment of the vouchers, 125.24 through 215.24. Do we have a motion? Any discussions on it? Okay. All in favor? Any opposed? Motion carries. Item 11, management report. Our CFO.
I'll apologize in advance. It is final reporting season, so you're probably going to hear a lot from me tonight, other than just the monthly financials. So I'm going to start with our kind of our open items that we have ongoing with the state, as those are fairly easy to tackle. Just as a reminder, we have the ISF conversation, our internal service fund, the My HealthLink state inpatient issue and dispute that we have ongoing there, and then the MAT rate that continues to be open. So since we last spoke, conversations have occurred on all those subjects, but ultimately no final movement or anything in writing from the state as to which way it's going to land. So I know Richard has stated our position. I think Tracy's had some conversations as well, but ultimately we're in the same spot. We've just talked about it a little bit more. So if there's any questions about that, as far as the ISF goes, we're planning to proceed as is. Our reporting this for fiscal 23 that we're submitting hopefully tomorrow is going to be under the same assumption that we've talked about before in our contract language and that kind of thing. So moving on to the final FSR. The final FSR, our financial status report, our Encounter Quality Initiative report, and our CCBHC cost report are all due tomorrow. About 10 days ago, I noticed that we had an issue with one of our foundational reports, happened to be called the EQI report out of our PCE product, and since then been working on those data elements. This morning I ran a new report, assuming that it was fixed, but we still had some errors. Literally, I think 20 minutes before I walked out the door to come to this meeting, we received an updated report from them. A high level look, looks like it's going to be okay. It does take a long time once those reports are generated to submit the final FSR and that kind of thing. So when I go home tonight, I have to run those reports and work on that. Our goal is still to submit tomorrow, but wanted to make this group aware that if there are any other issues with that report that we haven't foreseen, we may have to request an extension from the state. So not the ideal situation, but definitely wanted to make everyone aware that that's where we stand. And it would impact at least 2 or 3 of those reports. I think the CCBHC cost report could still go. Any questions about any of those topics so far? I'm going to go into the final FSR a little bit more, but if there's anything related to that. Okay. As I said, at this time, I feel like we have a pretty good handle on where things stand. The report I used to prep it, it's roughly the same expenditures in there. So some high level looks, I'll come back at the March meeting with final numbers, comparison to prior year and interim and some of that kind of thing. But we're expecting fully funded savings. So over $20 million this year. Fully funded ISF, which is at 43.5 million is what we're expecting. So those are all good things. We are going to lapse some money, but it's going to be considerably less than the couple years prior because of the way the CCBHC funding works. It kind of draws funding away from the traditional Medicaid and HMP plans. So our lapse is lower and we're able to save some of that money internally, which is nice. So we're expecting our CCBHC savings for local to be actually higher than last year. So those are local dollars that we can retain and spend on almost anything that we do here. So that's good news. So there's a lot of bright spots in the FSR, but I'm working on some of the details there. As far as the CCBHC cost report goes, we are expecting our PPS 1 rate to come down as a result of this submission. As a reminder, kind of on a 2-year delay with the state. So our fiscal 23 cost report that we're preparing right now to submit tomorrow actually impacts our fiscal 25 PPS 1 rate, which starts on 10/1/24. So we're expecting that to come back down. The reason is because we now have a full year of utilization under our belts with fiscal 23, and it's kind of right sizing our budget for the program. So these large surpluses, while they're nice, are going to be limited to 2 or 3 years. So we're expecting to run the program on a more break-even basis going forward, which is to be expected. So in fiscal 25. Any questions about any of those reports right now, or where we stand? Okay. I'll get into the monthly financials now. I'm just going to hit some highlights. So on page 2, we have our revenue and eligibles. you can see that the bars are trending downwards as we expected and talked about. Since we last talked, there has been some movement at the statewide level and discussion about ultimately where we're going to land as far as projections go, losing eligibles and ultimately the revenue related to that. So I know Richard, he compiled information from the other 9 PIHP CFOs and trended that out and compiled it, and it looks like we're going to land lower than we were pre-pandemic, which was not the goal of that work. So those efforts are ongoing, and Richard and I are both participating in that effort. So any questions about that particular piece? Going to the next page, nothing really to highlight there. The only thing I was going to say is we're working on settling 1920 fiscal year right now. So we are expecting to send $16.5 million back to the state, but that'll be a reduction in our cash and our liabilities. So we have that booked from prior years already. Going to page 5, I will highlight our CCBHC anticipated surplus. Just as a reminder, it's the CCBHC Medicaid and Healthy Michigan added together, so it's about $1.8 million through this point in December. So that's a good sign. Fully funded reserve and savings, as noted at the bottom. The CCBHC is another state work group that Richard and I are going to be participating in. I know the association wants to bring, the CMH association wants to bring some of the finance folks together and talk about how the CCBHC is funded and how that may have differed with some of the things that CMS and their experts have put together. So we're going to be sitting on that work group. That's a fairly new occurrence, but I think one of the key pieces there, which I'll get into in a minute, is funding for CCBHC non-Medicaid as well, which we're seeing for fiscal 23, we spent about $1.2 million on CCBHC non-Medicaid folks. And I think already through this point in the year, we're at 847,000. So that gives you, times that by 4, gives you a rough idea of where we might land at the end of the year. So that's going to be an initiative for us to push, and the state gave us $171,000 last year to cover that. So there's a huge imbalance between those things. So going to page 6, that was really the only thing I wanted to highlight there. We do have a general fund surplus, but it's offset with our CCBHC non-Medicaid deficit below. So it's about a $500,000 deficit together between these two funding sources. So we are working on state general fund, identifying, as the pandemic rolls down, individuals that are rolling off of Medicaid, some of the things we talked about, getting them re-enrolled, are they in the right services? Another issue we're having statewide is there's some folks, particularly on HAB support waiver, that have been switched over to a Plan First Medicaid program, and there is what we think is a system issue at the state, where those individuals have to be manually switched back to retain their eligibility, so those people are all hitting general fund. So all that to say, this number is constantly in flux. We're trying to, our billing manager is going through case by case of why is this person hitting general fund? Is it a legitimate general fund person? Do they need to fill out their Medicaid, and so on and so forth? So we are working the details and expect it to level off at some point. Any questions about the monthly financials?
Donna? If I can get this to work. Did I hear you say that you expect to be sending $16.5 million back to the state? Did you say that?
Yes.
Do you remember what we sent back last year? Was that 4 million or 4.5? Is that what my memory is?
Well, there's a couple things going on. I think the net of our CCBHC, so our Medicaid and HMP, CCBHC is settled separately, so those two together was about $4.5 million.
That's what I kind of
And we
remember.
were, I believe we're actually owed that though, from the state, if I'm remembering correctly. So this $16.5 million is actually from our FSR that we did 3 years ago.
Oh,
And we, at that time, we.
I just kind of got sticker shock when you said that, you know.
And
listening.
it's gonna be a lot more when we get to 21, 22.
Oh, okay.
So it's.
So
It's
get used
actually
to it,
gonna
is that
go
what you're
up.
trying to say?
Yeah, so
Okay.
during the pandemic, if as we recall, eligibles were very high and so was revenue. So we got a lot more revenue than was fiscally appropriate to use, really. If we would have spent up to that amount, we would now be in a position where we were looking at
So
deficits.
when does that money have to go back? At the end of September? Or,
So assuming that we'll settle with them in March, I would expect them to do a take back, so to speak, in our April payments. So when we get our check from the state essentially for our ongoing Medicaid enrollees, it'll be subtracted off of that. So
Okay.
it won't impact our current year revenue or anything, since we already have a liability booked for it. So it's just the ongoing process and the delay. So we'll have to, the year we're working on now might not be settled for another 3-4 years. So, yeah, absolutely.
Nick?
On the report that was emailed, it's not in this particular packet, but there was quite a bit of information about Medicaid ineligibles, or people becoming ineligible because of the end of the emergency period of the pandemic. And I've noticed that I'm correct in assuming that these are for full Medicaid for the county, not just for the CMH Medicaids, these charts?
It's everybody, yeah. It would be all enrollees in the county. So there are some, if they hit our system, we're reaching out to case managers. You know, can we get these people enrolled? If there's people that just don't touch the CMH system, yeah.
Yeah, where I was going is that the no response to renewal is the big batch. As we feared, we don't know whether they're eligible or ineligible. They didn't answer in time. I know we've had a tremendous outreach program to our members. Have we got any information as to what the numbers are amongst the people we provide services to in terms of how they would relate to these overall charts?
So Ken, the data that he was suggesting that the CFOs are collecting in March, so that should paint a better picture per region, kind of how this is going to impact us, but we don't have quite that information. But to answer your question related to ineligibles, the catch for us is if they're not ours, a lot of times we don't have that information. So that's where we're trying to do really broad public education. As you know, the Medicaid health plans, trying to get them to share that information. But if they're not ours, we don't have the ability to.
What really the reason for my question is I'm trying to determine whether or not our special outreach efforts to our providers were effective or not. Do we have any numbers that would tell us that yet, or can?
The only thing that I would suggest is the numbers that Ken mentioned that they're doing per region that Richard and them are working on. That's going to give us a better picture here, right? The numbers that I had shared in the report were kind of statewide that I'm assuming Alan, when he does come up, he will kind of provide an overview. So yes, we need to know more specifically how we are doing and did that make an impact?
Okay, so we don't
They
know
won't
that yet, but
until
we're
March.
trying to
They're
get.
finalizing in March, and I don't want to speak for you, Ken, but they're finalizing in March, and then they hope to grab those. And again, Alan can also wrap back around to this is kind of what that looks like statewide, and then again, we'll have our specific numbers, a better.
How that looks in Macomb and
Yes.
how it looks for Macomb CMH.
Correct.
Okay, very
Specifically,
good.
yeah.
And I'll just add to that too, we are, doing some tracking on our general fund, which is essentially where these folks would end up if they're losing their Medicaid.
Well, they may end up in general
Right.
fund, they may not, they may just go away. in terms of seeking
It-
services.
Yeah, if they continue to receive services from us, that's when they hit the general fund. So we are working on that. If there's specifics that board would like to see as to, I don't know if it's the service types by those, and we can provide that and any efforts and people that are re-enrolled during the year. I know our billing manager is on a monthly basis getting the no Medicaid report and sending that off to our providers as well. So, I mean, there's a lot of kind of detailed work being done right now to try to do that and move the dial to the extent that it's within our control.
And if this is helping Nick, one of the generalized way up here indicators is the number of people who are receiving services is still trending up, if that's helpful. In other words, we haven't seen, at least so far, right, a dip. So
That would suggest that we are getting them requalified.
that would suggest that. I think that's a way up here, but yes.
Okay, that's a good sign. It's just that, I mean, we all expected that there were going to be people who fell through the cracks.
Yeah.
Because they didn't have to recertify for so long and then suddenly had to. But when I see a number of 223,834, that's an even bigger number than I had anticipated. And if that trend, and that's for like 3 months, and if that trend continues, there's a real problem with people who need services, whether it's ours or other medical services, who are falling through the cracks. And some of them maybe no longer need Medicaid or don't qualify for Medicaid, that's fine. But these, we don't know that because they simply didn't apply. We know it from those who reapplied, how many were no longer eligible. And that's a much smaller number. Did apply.
It's worth noting too that getting the message across to the CCBHC program, assuming that's you have an eligible diagnosis and an eligible service code, that those individuals are not turned away. So they're hitting that non-Medicaid piece, but also trying to keep people engaged in services in that way as well. So,
thank you.
Yep.
Any other questions for Ken or comments?
Thank you.
Thank you. We're going to move on to a report from our interim CEO, Tracy.
I will be quick. I'm just going to give some high levels. You all should have received earlier today a report that has much more details behind it. So if you haven't checked it out, I would encourage you to do so. So kind of in line with that on the high level, one of the things that I wanted to draw your attention to is our media. So we've had some recent media activity and plan on activity. So Friday, we have an interview with MEA, or Middle Eastern Radio and Television. And then I don't know the length of time before that will air. We also have interviews scheduled on Monday with CBS News. Amir Jacobson, remember, she's also, because she's amazing, going to be our MC this year at the awards. But what she's doing is a profile on last year's winners. And then we're trying to get it out there so we can promote more nominations and, of course, celebrate the people who won last year. So that's being recorded on Monday, but we don't, again, know. But the goal is that it's soon behind that recording. Other things I want to draw attention to is, just as a friendly reminder, you all have this draft strategic plan, so I was going to give it until the end of next week for any feedback, and as stated previously, we welcome that. Also, I did add to you a new item. There is a CSU project charter or project overview, if that's helpful, is one of the first items in the report that I gave you. The goal of that is a simplified document to try to start educating. Kind of earlier when you were talking about the engagement center, one of the most important parts is kind of painting the picture for the community of what this is, but also what this isn't. So that's our initial document to start sharing that. You'll also, I did not put this in the report, but we do continue to make progress as far as possible locations. We do have some viable ones we're looking at. I'm not sure how those will pan out, but we have made progress in that particular area directly related to the CSU. Other one is we have had a number, including another one this week, of the Medicaid health plans reach out to us. they are interested in us becoming one of their behavioral health providers. So we are collecting information. We are not committing to that in any way or making any decisions or directions, but we're definitely trying to collect the information and gain insight in that. It does appear that the larger ones are trying to connect with Oakland, Wayne, and Macomb, and the way that they verbalized it is we're the biggest market, so they see value add in potentially partnering with us. Our biggest concern and question that we ask is we have to meet the needs of the people we currently serve, and that has to be our highest importance, so we want to make sure that we won't, that won't impact that essentially. And of course, we have lots and lots of other questions, but it is some good conversations, at least to learn some more. Let's see. Mental Health Matters, just I already mentioned it, but just a friendly reminder update, we have 58 nominations. Last year, I think we had around 120, so our goal is obviously much more than 120, so it closes April 1st, so just a friendly reminder if you have not done so or encouraged others to do so, and you will see in your social media and everywhere, we apologize ahead of time, but Kayla, who's going to introduce herself, we're going to start bombarding you with those, so we apologize ahead of time. And I think that is just a quick reference, and I do just want to thank Alan for being here. I'm excited to get your reports, and I think you'll learn that a lot of things he's giving updates on. Hopefully we'll share some additional insights to kind of the subject matters we were just speaking about.
Thank you. Any questions for Tracy? Okay, we're going to move on to item 12, other possible agenda items, and we're going to turn it over to Alan.
Great, well, thank you. Thanks for having me. Always enjoy making the drive over. So this is one of the more entertaining boards that I visit. So in a positive way, So I sent over a couple of handouts for you. So I'm not going to go through all that business that's in there, just so you have it as background. I also brought with me today two infographics or two documents that I actually gave to the Senator Santana's committee yesterday. She chairs the Senate MDHHS budget subcommittee. We had a group that was in front of her committee yesterday talking about what our members are doing across the state. So one of them is on CCBHC. Obviously, you all here are part of that effort. We had a group that pulled together really have been working on data outcomes with our CCBHC sites. So that's kind of a culmination of some of that. And again, I tell people that kind of tells the story of CCBHC and helps us advocate for dollars and permanency of the program. And then the other one is very related to the conversation you just had during the CFO report, something I'll touch on when I kind of go through what's going on with the budget in our advocacy, but around Medicaid rate, structural problems on the Medicaid side, things of that nature. So just wanted to bring those up. I had them printed off for committee, so I thought I would bring them to you folks as well. So kind of what's happening in Lansing these days. Let me start, they're in the middle of the budget process now. So the governor came out with her FY25 budget recommendation February 7th, so a few weeks ago. Legislature is now beginning that process of the House is having their set of hearings, the Senate is having their set of hearings. So we're kind of in that appropriations process that's kind of dominating what's going on. But let me jump to the policy side first, and then I'll come back to the appropriation side. So on the policy side, the legislature did return to Lansing on January 10th after a very unusual short fall legislative session. So they actually adjourned last fall prior to Thanksgiving. They were actually done voting on November 9th. Their last full official day was November 14th. It was the first time they adjourned prior to Thanksgiving since 1968. There's a bunch of different reasons why they did that. One of the main reasons, I think, as this community is well aware, there are a couple of members of the Michigan House of Representatives that won, various mayoral positions. So that created a vacancy there. As it turns out, in Michigan, we have 110 House members. Democrats had a 56-54 majority. The two members that won were both Democratic members, one of them here from Lori Stone. it brought the functional majority in the Michigan House to 54-54. So meaning, there is not a lot of function at 54-54. You need 55 votes to pass something in the Michigan House. The governor called a special election. Obviously, the primary was on January 30th. The general election is not going to be until April 16th. So really, for all intents and purposes, the House will not be back up to full strength probably until the end of April, beginning of May. So we have some time here where you're not going to see a whole lot of votes coming out of the House, although we do have the Speaker, Joe Tate, working with Matt Hall, who's the minority leader, of coming together kind of on a weekly basis saying, okay, here are the bills we're willing to kind of vote on for the week, and they're moving those along. But anything of any kind of, I think, real consequence, that's going to get held off until the Democrats get back up to full strength, including the budget. So I think what this sets up for on the policy side, and I'm going to go through a couple of the policy items we'd really like to see move this year, that really sets up two distinct windows to actually get something meaningful done this year, which is the end of the legislative cycle. Whatever doesn't get done at the end of this year, when they're done, whatever the governor does not sign into law, has to start all over again next year. So those two windows would essentially be, the end of April, beginning of May, until probably the second, third week of June, until they get the budget done. And then you're going to see the legislature will break for the summer. The House is going to go out campaign. They're up for re-election this year. Then essentially, whatever doesn't get done then, before they break for the summer, is essentially going to get pushed off until lame duck. I mean, they're going to come back in the fall. They're not going to do a whole heck of a lot, but it's going to be after the election in November. So I think we've got two windows to get stuff done. So what we're hoping to get done, and some of these bills are in the PowerPoint presentation that I gave you, but we've got a couple of mental health parity bills we'd really like to see get done. I mean, they're mental health and substance use disorder parity. Senate Bill 27, that bill essentially codifies the federal mental health parity law. That's all it does, puts it in the Michigan statute, does nothing beyond that. That bill passed the Michigan Senate back in the fall, is over in the House Insurance Committee. That's where it sits. Then we have House Bill 4707. This is Representative Brabeck's bill on mental health and SUD parity that actually expands parity in a couple of ways. One, on medical necessity. It actually talks about medical necessity being based on an actual mental health or substance use disorder professional recommendation based on actual scientific criteria, ASAM criteria, other criteria. It's not artificially based on, whatever the insurance company wants to set it at. So when they talk about, professional, being professionally based, it's based on their recommendation for scope, duration, length, set of services, etc. And then the other big change would be in-network, outer-network. The bill says if you, through your insurance company, cannot receive your services in-network, if you have to go out-of-network, the insurer cannot charge you anymore out-of-network than they do in-network. So a couple of really big changes. I don't believe they would necessarily impact people served through our public mental health system. It's really more for commercial or employer-based insurance. That bill is very much opposed by the insurance industry, is on the House floor. It's been on the House floor since last fall. My guess, if that moves at all, it'll be a lame duck issue. So we've got that going on. We've got a telehealth package that passed the House last fall, is over in the Senate. It's actually in Senator Hertel's committee, who chairs the Health Policy Committee. And then that package essentially says for insurance companies, for telehealth services, you have to reimburse telehealth at the same level that you do in-person care. So they can't have a discrepancy with telehealth versus in-person. Again, same rationale as the parity bill. I don't think that's going to impact people served through our public mental health system. That's more commercial, employer-based. And again, the insurers are fighting that package as well. They've slowed it down through the process, but Senator Hertel thinks he may get that out yet this spring out of his committee. And then hopefully we could get that sent to the governor before they break for the summer. We have a couple of bills up in Representative Brabeck's Behavioral Health Subcommittee on social worker licensure changes. The bills would eliminate the exam requirement for social workers to become licensed. We've kind of found working with different groups that the licensing exam is a barrier to social workers becoming fully licensed. Especially the longer you're out of school, the harder it is to pass the exam. They've done this in other states where they've eliminated the testing requirement. They replaced it with additional supervision. Michigan already requires like 4,000 hours for a social worker to become licensed, as far as on-the-job training, hands-on work, things of that nature. So we already have a pretty robust set of requirements there. This would add additional supervision to that in lieu of the exam. Again, this is not something that's going to just breeze through the legislature, bless you. It is the LARA, which is the state department that does licensing and regulatory affairs, obviously has a concern that limits some of their control. The entity that actually administers the exam has concerns, go figure. And then a couple other groups have some concerns as well. They've done this in other states. When they did this, the nearest to us is Illinois. When they did this in Illinois, they went from like 400 available social workers to like 2,000 the next year. Obviously, social workers are the dominant clinicians within the public mental health field. Workforce is a major issue, I'm sure, as you're very well aware. So this is something we're really pushing, hoping to get this through. I think the goal would be to get it out of the House before they break for the summer, and then hopefully it could get done in the fall in the Senate. That's the goal there. And then lastly, I'll touch on Open Meetings Act. Knock on wood. We've been pushing to get an Open Meetings Act change for quite some time that would allow for remote voting, remote participation for non-elected boards. There's a bill in the House. Hopefully we're able to move that through yet this year. The legislature has been, they've been really dragging their feet as far as getting changes to the Open Meetings Act. They're very much against elected boards having this flexibility. But again, we continue to make the case for non-elected boards. Obviously, our membership has some unique circumstances considering who is on CMH and PHP boards, especially you get, north of Lansing, you've got multi-county boards and things of that nature. So hopefully we're able to see some movement there. On the budget front. So that's kind of policy side, kind of what we're hoping to see in some, limited timeframes. I mean, there's other bills that come up all the time, but that's kind of on our wish list for the year. On the budget, let me just first touch base on I guess what the governor included, and then I will hit lastly what our main concern is with the budget. So one of the documents I sent over kind of goes through what was in the governor's recommendation. Again, last year's budget was, the largest budget in the state of Michigan history, $87 billion. This year's recommendation is a little under $81 billion. So it's less because they've spent all the one-time money they had. The budget this year, I think, is going to be relatively flat. There's far less flexible dollars for them to spend this year than what they've had the last couple of years. So I think it's going to be a little bit more challenging. When you look at the investments on the behavioral health side, careful how I say this sometimes. The investment in CCBHC is probably the single largest investment in mental health and substance use disorder services, probably since, the state went to, managed care. When we really started ramping up Medicaid investment, I mean, that's probably the single largest investment. It's more than Healthy Michigan. I mean, it's more than autism. I mean, it is. When you look at what the governor's proposing this year, that the CCBHC line item goes up to over $550 million. So it is a significant increase the state is making. Beyond that, there's not a whole lot else in the budget recommendation. So I'm careful I'm not criticizing the investment, but that's the only place where it really exists. So on the governor's recommendation, she included over $190 million, again, for CCBHC expansion. They are proposing, they believe that money is probably enough for 11 to 13 additional sites. So, you know, they'll go through their certification process, but that is what they're proposing in the budget. That brings that line item up to the 557 that I mentioned. Beyond that, they have $36 million in the budget for Medicaid rate increase for mild to moderate, but that goes to the Medicaid health plans. There's $8.3 million in there for peer recovery specialists, but those are for individuals in hospitals. They're on the direct care wage side. There is no additional direct care wage increase in there. What was included in the governor's recommendation is an 85-cent increase for non-direct care nursing home staff. So staff that did not get the 85 cents last year, they would get that. Beyond that, there is no additional direct care wage increase in the budget. Now, last year there was 85 cents, the year before it was 235. There were others prior to that as well, but there is nothing in the budget this year. There is $3 million in there for behavioral health workforce supports. It's one-time funding, but again, that's going to be allocated to colleges and universities in the shape of scholarships and internships, things like that. There's $10 million in the budget for nursing incentive program to recruit and retain nurses. Half of that goes to state facilities, and then the other half is for the community. There's $300 million in the budget for school mental health and school safety. And again, that goes to school districts, and that's been an issue across the state where money that goes to school districts for them to increase their staff typically means they're taking staff from our CMH and provider network, which is obviously problematic. And then I'll end on a positive note, and then I'll touch on some of our stuff. There is in the governor's recommendation, we have been working with MAC and the Sheriff's Association to encourage the state to do an 1115 waiver for individuals in local county jails. So the governor's budget does include $30 million, it's $30.5 million in the budget that would extend Medicaid to individuals in local county jails 90 days prior to release, or if they're not in 90 days, it would essentially allow them, if they are not adjudicated, would allow Medicaid services to be provided to those folks in the local county jails, which would obviously save, either if you're providing that directly, it saves you or your county significant funds. So something that we've been working on, pushing on for the last year or so. Still working with MAC and the sheriffs on what the detail would look like, but that's certainly very good news on that front. So that was kind of what was in the governor's budget. Let me just touch on, I think, our biggest single issue that we're going to be talking about with the budget has to do with the handout that I gave you on the Medicaid rates and kind of what we're calling some of the structural problems. So as was kind of noted in your CFO report, the Medicaid redetermination, Medicaid rate issue is going to be, I think, a gigantic issue this year. So, as was noted, during the pandemic, Medicaid caseloads hit an all-time high. I mean, it was over 3 million people. Prior to COVID, Medicaid caseloads were about 2.2 million people on Medicaid. The inflation over the pandemic over the last 3 years, we indicate was probably 19.5%, 20%, which is probably about 6.5% every year. The increases that you received and our other CMHs, PHPs received were not that high. And, we suspect that the artificially high caseload that was kind of stuck due to not being able to do redetermination really offset or covered up the underfunding of the system over the last couple of years. I mean, you know, and you had during the pandemic, you received tons and tons of money. People weren't receiving services, and we had all this money out there. Now we're going to see the exact opposite of that. Last year's Medicaid rates certainly were dropping, and now we're going to see less of a rate. Hundreds of thousands of people are going to come off Medicaid rolls. We are certainly going to advocate that the state adjust those Medicaid rates as people drop off. They have to adjust those positively. The other big issue that's going to happen is making sure people get, and you mentioned it earlier, slotted in the correct Medicaid bucket, which is a huge issue. And we found this out painfully a few years ago when Healthy Michigan started in Michigan. We had about 40,000 people in the state of Michigan that were on Medicaid, disabled, aged, and blind, got shifted over to Healthy Michigan when they went through the redetermination process. And I mean, as you probably know, the difference in reimbursement is enormous. I mean, it's almost $400 per person per month compared to $40 per person per month. When you do the math over 40,000 people, you're talking about a $100 million deficit. So we had to fight with the department, finally get them to, yes, agree that there is a problem, negotiate back and forth on what the number was, work with the legislature. I think we ultimately got about $60 million back. So our fear, as we go through this exercise this year, we're going to have hundreds of thousands of people coming off on the front end. If people get miscategorized, put in the wrong bucket, there is a process to get them moved over in the right bucket. That takes time. The amount of reserves that we have is not going to be sufficient to sustain a prolonged drought as far as Medicaid funding. I mean, it will cause some significant problems. Our initial projections, it looks like the drop-off in caseload is steeper and deeper than what the state initially thought. Right now we're looking at maybe $190 million to $200 million deficit for the fiscal year. Bob and I are expecting to get updated numbers from the PHP CFOs sometime probably next week, early March, the week after, something like that, that we can then use to go back and have another conversation with the department. We've already talked to them, but then reach out to legislators. I've already done some initial work, have given them this document, have tried to walk them through this scenario of, you all are impacted by this process far different than hospitals or health plans, where the people that come off and come on, people that are coming off, your costs don't go away as those people drop off. They do if you're a health plan. If people drop off, you don't serve them, and the costs go away. But for us, I mean, we have pretty much a dedicated 300 to 350,000 people that we serve across the state. Those aren't the ones that are dropping off of this. So, and our costs continue to go up. In the Medicaid rates previously, they did not include things like staffing increases, provider increases, just the cost of doing business has gone up. Those rates haven't reflected that. So, I mean, this is going to be the single largest thing we're going to talk to them about. Again, keep in mind, at a time when the budget's going to be relatively flat, if we have a several $100 million issue, this is probably the last thing they want to spend money on. They want to look at, new cool initiatives and things like that. And we're going to dig into this in the weeds here in a couple of weeks. I don't necessarily know if they need to allocate a couple $100 million more. One of the issues that we're finding is the line item that the legislatures appropriated for Medicaid mental health. They're not sending all that money out. They are some of that money is getting held back. The first quarter, there were like $43 million that was not sent out that could have. Now, I think that has to do with caseloads being high. Now they're coming down, plus rates are lower than what the costs are, and that's why they're not sending all of that money out. But part of the pitch to the legislature is you've already appropriated this money. Push them to send that out to the system, and maybe you don't need $200 million of new money. You only need fill in the blank, whatever that number may be. But that's going to be really what we're going to be talking to the legislature as far as our budget ask. And we've got other budget asks, but I mean, that's going to be by far the single largest. So with that, I will stop rambling and see if folks have questions.
Nick?
Thanks, Alan, for an excellent report, an extensive report. I was really impressed with the number of things that are going on. I just want to make a couple of comments on the Open Meetings Act changes that you were talking about. Actually, I think you should go hybrid for everything. And if you need backup, folks here can help you, because during the pandemic, when we were allowed to go hybrid, our board membership participation was much higher, but even more than that, you can see the number of people participating in the public here. When we were on a hybrid or even on a Zoom presentation, we'd have 100 people in the participating in a lot of the meetings, not necessarily talking, but at least there. And the reason for the adoption of the Open Meetings Act was to make government accessible and known to the public, that the public would know what was going on. With all due respect to all of my friends here in the audience, most of them, a good hunk of them are actually staff. And it's good that they're here, but that having 100 people on a Zoom line is even better. So we'll be happy to give you chapter and verse with the legislature. On an administrative question, I've gotten different reports from different groups as to the status of the conflict of interest changes that the feds, as you know, were a joint PIHP, CMH, SP, and we're one of the few CMHs that provides direct services, which means we will, if what they were talking about doing was going to put us in the difficult position of having to have people come. We have trouble getting people to come in the first time, come in twice before they can get services. That's not good for the consumer. For us, it's a pain, but for them, it's problematic. What's the status of all of that?
I mean, there's still nothing final. We actually have, through the association, a meeting tomorrow with some of our members, kind of talk through some of the different scenarios in the survey. I know that the state has contracted with an entity that put together a survey that they're sending out, basically wanting to know how they're functioning, who does what right now, who provides direct, who contracts out, what that looks like. They're going to collect that information and then make some recommendations. Now, the state is waiting on getting guidance from the federal government, from CMS, on if you're a CCBHC site, you would be exempt from the conflict-free access and planning, because that's part of the CCBHC program, which, that would exempt you folks here. But then, the department I was on a call with them earlier this week talking about, well, we still may have to look at, even with the CCBHCs, maybe we have something else that they have to do and some other track. So they're still working through that. But again, I mean, to your point, I mean, it makes very little sense to separate out some of those functions, to have individuals tell their story multiple times. I mean, I guess that's bureaucracy and how that works. But we are still continuing to explore and push for exemptions, trying to find workarounds to that. I mean, maybe in entities such as Macomb, maybe there's some kind of firewall that has to be set up, but we're not actually separating out some of the functions. So there's still a lot of discussion. No final decisions have been made on that, although I know some of the deadlines are coming up here fairly soon, but nothing is final yet.
Well, one of the advocacy groups I'm involved with was basically told it was gone, as a proposal. What you're telling me is it's still around, but there's a lot of details. The devil's in the details.
Well,
and
I
there's a
mean,
lot of
essentially
devil.
what the state was originally proposing, they decided to say, okay, fine, we're gonna scrap it. And then they kind of came back and said, okay, fine, 10 PIHPs, we'll go ahead and figure it out. And then you do it, you all need to figure it out. And then I think they've kind of pulled back from that. Now they're working with a contracted entity of, well, maybe we want to set up some kind of a uniformity across the state. So that's why they're doing this survey, and they're going to kind of get the lay of the land and then maybe come back with some additional
It seemed to me that the concern was legitimate, but the cure was worse than the disease. And
exactly
in terms of what was being done. I'm delighted to hear you talk about the CCBHCs, and I'm disappointed on the direct care workers piece. But on the school piece, the money's flowing, and yeah, it's creating this conflict. Is there any discussion about trying to incentivize school districts contracting back with CMHs rather than us fighting? We should be sharing, and we should be working together. And I think we're contacting them, aren't we?
We are the supplier
Aren't
of
we?
some of the
Because
therapists in the school districts, yeah.
That would make more efficient use of very limited staffing
Yep.
ability if they contracted with us, and we could then disseminate staff accordingly.
And that's in our, when I give legislators our budget recommendations, I mean, that is kind of our exact recommendation on that of encouraging collaboration between the two. And a lot of it really, it boils down to community by community on how that works. I mean, you probably have some school districts here where you don't, some that you do. I mean, some counties, it works better than others. So yeah, I mean, that's the tough part of how that works.
It would be nice to have some sort of state incentive to do it, but I agree the onus is on us, not on the state for that. Two last quick ones. The partial elimination of the Medicaid disqualification for jail inmates is a step forward. Quite frankly, I've been advocating for years for the elimination of both the IDF and the jail and prison eliminations or disqualifications, because the reasons for doing that in the 60s were valid. They don't exist anymore, and it doesn't make any sense. And if we could have CMHs and Medicaid continue for people in jails and prisons, particularly those are getting out, which is vast majority, you could have a continuity of service from going in, during, and after along the line. But on Medicaid generally and the GFP piece, one of the problems we'll face is with the reintroduction of the spend down issue. That recreates the spend down problem, and that's general fund. Is there any discussion on beefing up the general fund to deal with that spend down problem, or some other way to deal with spend down?
Yeah, no, I mean, there's not. And again, kind of going back, I mean, obviously you're probably more aware than others, but what we're going to hear back from legislators is, well, we don't have as much money as we had last time. So, I mean, just on the general fund side alone, I think, we've got a couple of different asks. I mean, we have the GF piece on the CCBHC is a big deal. I mean, we're trying to figure out how do we increase that, because there's an obligation. There is, to your point, the GF line has been, flat for the last number of years. We've also have been advocating to eliminate the local match drawdown, which is the amount of money the state takes that counties give CMHs. The state still takes $10 million of that and uses it to draw down Medicaid. They were taking 25. We were on a 5-year phase out of that. So you could keep your local money here and use them towards those initiatives, but the state has been using it for Medicaid. So, we need to replace that 10 million with state GF. So we have an ask there. So we have a number of different GF asks, and my hunch is we're probably not going to get any of that in the budget.
But try, right?
Yes, exactly. So yes, so no, we continue to advocate for non-Medicaid flexible dollars are certainly very useful.
Thanks, Al.
Thank you.
I have a question on the Open Meeting Act. Would you be able to vote remotely or no?
I think that that is the intent. It would be to participate, and I think you can participate now, you just can't vote. So I think it would allow for participation and voting as well.
Because it's not the law right now, correct?
No, that's correct.
That's not the law right now.
And for counting for a quorum.
Right, you have to have a quorum. You gotta have at least a quorum. Correct. Okay, good job.
Any other questions for Alan? Well, thank you for taking the time to drive out. We always look forward to hearing from you.
No problem. Happy to do it.
So a couple reminders. We have the CMH Board Program and Budget Committee Wednesday, March 13th at 6 p.m. here. And then we also have the CMH Full Board Meeting Wednesday, March 27th at 6 p.m. here. So we're going to go ahead and move on to hearing of the public. Anybody from the public wishing to speak? Come on up. Please state your name and your address.
Hi, I'm Kathleen Lewandowski, CEO of Carl Walk Jump Run Therapy Clinic. I spoke last month about some of the struggles that we were having and reduction in speech rates. So we're working on Daniel Gornge with that right now. But I wanted to share some wins. So we just got our 3-year car-free accreditation. So we were super excited about that. It was a big fee, especially because we had reduced some admin. So everyone in my organization took on that personally to help. So we're really excited about that. We just got that word yesterday. And then I wanted to share a couple of KPIs. So we measure on our effectiveness. So for last year, when we compiled the numbers, 90% of our patients are meeting greater than 80% of their established goals at plan discharge, which we have OTPT and speech. So often they're very involved patients that we need a lot of continuity of care and integration of the discipline. So we were really proud of that. It was improved from 2022. As far as our clients' satisfaction, when we survey them, 90% are satisfied or greater with our services. We were really happy about that. Of our staff, 100% of them did a reflection and survey on their yearly appraisal. And then as far as our access goal, 78.5% of our patients are scheduled within 3 weeks or less, and then 66.2% are within a week. And a lot of times they have multidiscipline, they have limited availability, they might be in a day program, they might be in school. So we were pretty happy with that, and we just wanted to share that with our stakeholders and tell you thank you for your support and just give some good news as well.
Thank you. Anybody else from the public wishing to speak? Come on up.
Good evening, everyone. My name is Kayla Collins. I am the new CMH Communications Manager. So I wanted to come and introduce myself and give you guys a little bit of background on me. I've been in communications and PR for about 9 years now, managing campaigns through Metro Detroit, more specifically in Macomb County with Care of Southeastern Michigan and a few others. To Tracy's point, we have a lot of great things coming your way, and I'm super excited to be here and be in support and help expand our visibility with CMH and the dynamic things that we're doing with the dynamic people that we support. And to that, I did also want to give you guys an update for Airfoil's budget or board reports. We will be sharing a quarterly report in the March board meeting that will showcase or highlight all of our successes and campaigns that we've been working on thus far this year. So thank you so much for your time. If there's anything that you guys need on a communications or marketing standpoint from CMH, I'm happy to support. Or if you guys have any questions about anything, I'm always here.
Well, thank you. Welcome.
Thank you.
Anyone else from the public wishing to speak? Anyone from the public? Okay. Do we have a motion to adjourn?
So moved.
All in favor? Thank you, everybody. Have a good evening.